Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest tonight is Dr. Kristin Harts. Welcome, Kristin.
Thank you.
Kristin is a rheumatologist with the Iowa Arthritis and Osteoporosis Center, and she is an expert on osteoporosis in addition to other rheumatologic disorders. And that's going to be our topic tonight.
Love
osteoporosis.
I love it.
So, but before we learn about osteoporosis, let's learn a bit about you. Where did you grow up?
Cedar Rapids, Iowa.
So you're an Iowa girl through and through.
Yep. Went to Iowa State.
Okay. What was your claim to fame in high school?
Oh.
Sports,
Not
music,
getting arrested.
Not getting arrested. You were good at that. Okay, good.
I mean, I'm of the age group. Maybe you are, where the drinking age was 18 when we went to college. And,
yeah.
My claim to fame. I guess I was voted craziest.
The craziest. That's good.
In my high school class on graduation.
I think that's maybe even better than most likely to succeed.
Yeah, and probably not surprising to you either.
And so, you went to Iowa State. What was your first major when you showed up at Iowa State?
My only major was psychology because I didn't have to take any math classes.
Okay. So psychology, what did you think you were going to be?
I had no idea.
Okay. But you were interested in psychology because you were voted most crazy. So
right.
it was,
so
you thought, well, I better learn about this.
Yeah.
So at what point did a psychology major decide to become a physician?
Yeah, that was not my intention, not even on my radar. And I had such fun in college at Iowa State. And then I graduated and I was struck by the responsibility of needing to get a full-time job and what I could not do with a baccalaureate degree in psychology. And so I looked around at graduate schools, and I had done well in college and realized really the only skill I had was taking tests. So I had better go on and do some more schooling.
Mm-hmm.
So it came down to law school or medical school. And I went to take the law school admission test back then when we used to go to the Kaplan test prep centers. And a gentleman came up to me and said, well, you should go to medical school. And I said, okay.
So it was at the Kaplan Test Center. So was this before you took any of the tests, or you took some tests and
I took the LSAT. I took the law school.
And he thought from your LSAT answers that you'd be better at an MCAT test.
No, I got a scholarship to University of Nebraska in law, but I just.
So you did apply to law school.
Yeah, I did, and
got accepted.
But I just, my neighbors, I think my parents' neighbors were both attorneys, and they said, "Oh God, don't be an attorney." So I thought, well, my next option was medical school. So.
Okay. And so did you ever work in the field of psychology before you went to medical school?
I did, and I did a lot along the way as what we used to call psychiatric assistants or nurses' aides, mostly in Omaha, Nebraska. That's where I ended up after graduation by default.
You weren't at like a Douglas County hospital, were you?
No, I was at Richard Young, I want to say.
Okay. I did my psych residency, Creighton Medical School, at the Douglas County.
Oh, yep. Went there during medical school because I went to medical school at University of Nebraska. So we rotated over there, but yeah.
Okay. Yes, when I was there, it was the VA hospital where if you were an even number Social Security number, you were assigned to the Creighton Medical School team. Yeah. If you're an odd number Social Security, you were assigned to the University of Nebraska.
Right.
Because they both used it as a teaching hospital.
Yep.
So from medical school, what's the route to become a rheumatologist?
So then I got into medical school, and that was my talent, was taking tests. So I did okay with that and decided I actually was interested in it. And this is not traditional. And met my husband, who is now my business partner and a physician in rheumatology. And the funniest thing happened. I had decided to do primary care, probably internal medicine, because that opens up some other, you do 3 years of internal medicine and then 2 or 3 years of rheumatology fellowship. And he had been wanting to do rheumatology since he was born. So
I don't know anyone that.
yeah, it's very odd. It's very odd.
Okay.
Very odd. But I came up with the idea of, hey, let's do rheumatology and we could job share. And if you know my husband, he
Yes.
was like, okay,
Yes.
all right.
So were you both in the same medical school class?
He was 1 year ahead of me.
Okay. And then where did you guys do internal medicine?
We did internal medicine at Methodist Hospital
In Omaha.
in
Oh, no, in Des Moines. In
Yep.
Des Moines.
And the University of Iowa campus.
Gotcha.
Yeah.
And then a rheumatology fellowship.
Fellowship in Columbia, Nebraska. Columbia, Missouri.
Columbia, Missouri. Okay. And then you've been in practice, the two of you, here in Des Moines
21 years.
for 21 years.
Boy, did that go fast.
Wow. Yeah.
It's been wonderful.
And as a rheumatologist, how would you describe rheumatology? What does that entail?
That's a good question. When I first started in rheumatology about 20 years ago, I think at that time there was an estimate that 70% of mothers of rheumatologists had no idea what a rheumatologist was. And that's changed a little bit with the internet, but rheumatoid arthritis, lupus are the diseases that you most commonly hear about, autoimmune diseases. And as part of that kind of skeletal system, osteoporosis is one of the things that we do. Not all rheumatologists do that. It tends to fall either with endocrinology or rheumatology, but endocrinology, as you know, is so busy these days with all the diabetes in the world that you see a lot more rheumatologists doing osteoporosis. So,
Gotcha. And so we're going to now focus on osteoporosis. So obviously a very important disease. Maybe put in perspective the incidence of osteoporosis. Who's at risk? What's kind of the burden of osteoporosis in the United States, and maybe compare and contrast that to other places in the world?
Yeah, so I knew you were going to ask me that, so I made sure I looked up my statistics. So 10 million women in the United States have osteoporosis. 50% of women living in the United States will have a hip fracture or a fracture sometime in their life. And 25% of women that have a hip fracture will die in the first year that they fracture.
Wow.
$25 billion a year is spent on fractures. How that contrasts to other cultures, I'm not sure that I can give you too much data on.
And in the United States, what would you say are the modifiable risk factors, or what are the risk factors, for osteoporosis, and then which ones of those can we modify?
So age is definitely one. Loss of estrogen, so moving into menopausal status, or in men, loss of testosterone are risk factors. Lack of calcium intake, smoking, alcohol intake, and then something that you and I commonly see is medication exposure, particularly prednisone or steroid exposure, or some of the other medications that are used.
And is it true that women are more likely to get osteoporosis than men?
Women are more likely to get it at a younger age and to suffer bone loss at a younger age, but men don't get tested as frequently.
Mm-hmm.
So, for example, women start losing bone mass in their mid-30s, and that's our peak bone mass. Men don't really start to lose bone mass until their late 60s. And when we, as rheumatologists, try to get a baseline study for osteoporosis, which is a bone density test, it's quite easy to do for women. If you are in menopause, if you've been a year without menstrual periods, you can get a bone density test. But the guidelines for osteoporosis screening in men are tougher. 70 years of age, and there's not much else that you can pick up on to try and get a bone density test paid for. You can rely on x-ray changes depending on what you see on an x-ray, but the that depends on how the x-ray
Yeah.
is done.
So the hallmark of diagnosing osteoporosis is this bone density test,
It is the
correct?
bone density
It's not
test.
it's not a blood test that's
Right.
really for osteoporosis. You can check somebody's calcium level and you can check their estrogen levels or their testosterone level, but the actual diagnosis of osteoporosis is a bone density test.
Right. And properly what's called a DEXA scan,
Yeah.
DXA.
So explain what is a bone density test and what are some of the other names? DEXA scan.
DEXA scan, bone density test, or bone mineral density test. And there is one other test on the market called a quantitative CT, where you can get a CAT scan done to look at bone density. I think us hardcore osteoporosis people are a little skeptical of that because it tends to overestimate bone loss by quite a bit. There's a lot of radiation. The cost is quite a bit more. So the DEXA scan, or bone mineral density test, is the standard procedure, and it involves a very, very low beam of x-ray. When you have it done, you're sitting in an open room on a regular exam table. The technician's in the room with you, and you lay back on a table, and they run kind of a bar type of thing that just goes sort of up your body and back down. There's no tube, there's no enclosure.
It's an
there's
open room, no claustrophobia.
Easy to have done.
You don't feel anything.
No pain, no needles, no IVs, nothing, and takes about 10 minutes.
And the idea is that this gives you an x-ray image of certain bones, and that from that image you can calculate how dense those bones are. And there's some standard bones that the tables have been developed around looking at how dense certain bones in our body are, and then using that to determine whether your density is normal or abnormal.
So what we're really trying to do is quantify who's at risk for having a hip or vertebral fracture and preventing that. That's the whole idea of the bone density test. And the bone density test, a standard bone density test, will get a measurement of the lumbar spine, L1 through L5, both of the hips, and then the neck of the femur. And so you'll see on a report femoral neck, and it's not your neck. Patients always think that, but the femoral
neck. So the
neck.
upper part of the femur, which is the long bone of the thigh.
Long bone of the thigh. And at the neck of the femur, where most people have hip fractures. So those three measurements are what we like to try and get. Sometimes, as you and I talked about, you can get a forearm measurement if you need a little bit of extra data. But I think the important thing to realize about that is that you're trying to get sort of an idea of osteoporosis as a systemic disease. So you're trying to catch a couple numbers that might give you an idea of what's going on with the whole skeleton. So, sometimes I'll see patients and there might be a really low number in the hip, and they feel better that their spine isn't as bad. But the truth is, it's a systemic disease. So we're really trying to just kind of get a pinpoint of what's happening.
And there's certain, over time, there have been these locations that have become standard that you're going to measure, and then you've got data, population data, for what those are and how they correlate to your risk of developing a fracture.
Right. So you have the bone density done, and they measure the density of the spine and the density of the hip and the neck of the femur, and they do all these statistics and come out with what's called a T-score. And that tells the physician or the person interpreting the report whether your bone density is normal or there's some bone loss, which we call osteopenia, which is before osteoporosis, or if there's actual osteoporosis there.
Okay. And so back to risk factors. So you mentioned being a woman, especially a woman after the age of 30, and then in particular after menopause.
Really, yeah.
And why does osteoporosis become accelerated after menopause?
So before menopause, Many things in the body are regulated, like every day you have bone turnover and hair turnover and skin cells turnover, and the balance of estrogen and progesterone and living and dying cells is pretty much an even keel. And then after menopause and through menopause, as estrogen declines, that all gets kind of out of balance. And so as a result of that in the bones, there's bone buildup cells and there's bone breakdown cells. And so what was previously evenly matched to make new cells every day now becomes the bone breakdown cells really taking over and breaking down a lot more bone than the bone buildup cells are able to keep up with.
And part of that is regulated by estrogen. So
Estrogen,
as women
very
go
much
through
so.
menopause, their estrogen levels
Drop.
decreases, and that has a big impact on that bone physiology.
Exactly. And the strength of bone.
Are there things that women can do either before menopause or after menopause that will reduce the risk of getting osteoporosis?
A big one is calcium intake. And usually, it's even before menopause, it's not a bad idea to take a calcium supplement. After menopause, we recommend between 1,000 and 1,200 milligrams a day of calcium, not more. Vitamin D deficiency, treating that and avoiding that. Weight-bearing exercise is a good idea. You can improve bone density maybe 1 or 2% in an avid exerciser, but the more important thing about that is keeping muscles strong and preventing falls that then lead to fractures.
Gotcha. So the exercise in and of itself has a minor impact on bone density, but a bigger impact on actual muscle strength that
And fall prevention.
prevents falls.
Right.
And that calcium and vitamin D. So let's say an average person in Iowa, at what age should a woman start thinking about taking vitamin D and calcium?
So it depends if you are getting good dietary calcium intake, drinking milk and that kind of thing.
Eating yogurt,
Eating
drinking
yogurt,
milk, cheese, dairy products in
right,
general.
dairy products, right. Calcium,
What are the others?
cottage cheese, cow milk, natural dietary calcium. So things like almond milk and orange juices that are fortified with calcium are a possible source, but they're not natural sources of calcium. And so again, peak bone mass happens around the age of 30. So really around the age of 30 is when a woman should start thinking about taking a calcium supplement.
Okay.
Or better yet, eating more dietary calcium.
And the vitamin D, for most people probably know this, but our body is able to convert some natural things in our skin with the help of sunshine into vitamin D, and that we're more prone to be vitamin D deficient in the winter than in the summer.
True. Although people that are vitamin D deficient, whether they're exposed to sun or not, will still be vitamin D deficient.
Even in the summer.
Yeah. There's a gentleman, Dr. Haney, who has passed away in the last few years, but he was a researcher at Creighton in vitamin D, and it was his life passion, and he did that. I think he was almost 100 when he died, and he did that since the age of 30, and he took road workers in Omaha, Nebraska, at the beginning of the season before they had really dark tans and measured the vitamin D levels, and then again at the end of the season. And even those people that got really an intense amount of sunlight, if they were vitamin D deficient at the beginning of the season, really didn't gain much vitamin D from the sunlight. So sun helps in people that have the ability to transform that into active vitamin D, but it isn't a guarantee that you're going to increase your vitamin D.
So I've read something, and this was more in the lay press, but more like a medical journalist, that something like 90% of Americans are vitamin D deficient. Do you think, does that sound?
Particularly in the Midwest, it is
Really?
epidemic in the
And
Midwest.
why is that?
Part of it is the Scandinavian population
Mm.
that has come, originally during immigration. Part of it is the sunlight exposure. Um, but it's striking to me when we check people's vitamin D levels that people can have undetectable vitamin D and the person next to them can have a level of 30, which is just fine. So it's hard to predict
Mm.
by, looking at someone or judging by their lifestyle when they're not on a supplement who's going to have low vitamin D. You really don't know until you check a blood level.
And is just like the vitamins you buy in a grocery store, vitamin D3 and calcium, are those fine for taking over-the-counter
Yeah,
products?
vitamin D is adequate. D3 is more easily absorbed for most patients. You can take too much vitamin D, so a whole lot is not better.
Mhm.
It's probably a good idea to kind of know your baseline and talk with your doctor and see how much you need, because you can't just say everybody needs 1,000 units of vitamin D. Some people need 5,000 units. Some people need 1,000 units. Some people don't need a supplement at all. Calcium is a lot more tricky. So most people, we recommend between 1,000 and 1,200 milligrams in their day of calcium. But there's a lot of caveats to that. So, for example, if you've had kidney stones, you don't want to take calcium carbonate because that can precipitate kidney stones. If you are on any of the proton pump inhibitors like omeprazole and Prilosec and Prevacid, or Pepcid, or any of the stomach pills, as I call them, all of those inhibit the absorption of calcium carbonate. So those patients need to have calcium citrate.
Mm.
So it has to be calcium carbonate or calcium citrate. There's a lot of supplements out on the market, algae calcium and bone buildup calciums like calcium hydroxyapatite. I see different ones every day. The bony matrix can really only use calcium carbonate and calcium citrate. And you can't take carbonate if you have kidney stones or if you're on a stomach pill.
Okay. So can everybody take the citrate form?
Yes,
So that would maybe be safer.
that would be preferable.
Is take calcium citrate instead of calcium carbonate.
Mhm.
Let's transition a little bit into the association of osteoporosis with some cancer medications. Well, let's talk maybe medications in general. You already mentioned one, which is steroids like prednisone or dexamethasone. And patients with, for example, COPD, emphysema often have steroids as
Right.
part of their management and don't realize that among many things that can happen is developing osteoporosis. What are some of the other chronic diseases for which steroids are part of the treatment? Many rheumatologic
Yeah, in my clinic,
disorders. Yeah.
everyone.
Yeah. So lupus and
Lupus,
rheumatoid arthritis.
rheumatoid arthritis, vasculitis, psoriatic arthritis, ankylosing spondylitis, all of our inflammatory autoimmune diseases. But you also see a lot of, like you said, prednisone use in emphysema. Um, people use them, I think, somewhat regularly in colds that are severe or allergies. Sometimes,
Mhm.
hopefully, not on a long-term basis, but. And the indication is if a patient needs 10 milligrams of prednisone or more for more than 3 months, that they ought to actually be placed on an anti-osteoporosis drug, no matter whether they have osteoporosis or not.
Oh, really? So let's talk now about the medicines specifically for osteoporosis. So there are oral medicines and injections and various, what are the various classes of medicines that are used to treat osteoporosis, and how would you approach someone who has osteoporosis? Which do you start with, and how do you escalate that to some of the infusions?
So I think the simplest way to start when I explain things to patients is, do we want to use a bone stabilizer, or is this a situation where we need an anabolic or bone building drug?
Oh, so you can have some medicines that just stabilize things and others that actually
Rebuild bone.
rebuild bone.
Yeah.
Okay.
And it's that's something that's changed a lot in my career, even in the last 5 or 10 years where we've had new drugs that can replace bone and build bone as much as 30%, which is a tremendous breakthrough. The typical, and those are kind of, at least from my standpoint, drugs that we save for people that fail more conventional therapies. Now, there's people out there that say, hey, we should start everybody with a bone building drug, but that's very costly. And a lot of those drugs have lifetime limits. So you're sort of
Okay.
playing your ace before you might
So let's go
actually
with the
need it.
stabilizers first.
Stabilizers are usually where we start.
And what are those?
So the typical ones, bisphosphonates are the biggest category that you hear about, and that's Fosamax, which is alendronate, Actonel, which is ricidronate, and Boniva, which is ibandronate.
And these are oral.
And those are oral medications. There's one there's two IV bisphosphonates. One is, there's actually three, pamidronate, which I don't see people use too much anymore. Boniva, which is ibandronate, is an IV bisphosphonate, also not used as frequently anymore just because you have to use it every 2 months. The most commonly used one now on the market as an intravenous bisphosphonate in that Fosamax family is zoledronic acid, which is also known as IV reclassed. And that's given once a year as an IV.
Gotcha. And is there any evidence that the IV is better than the oral?
Yes. So, and the biggest thing about that is, one, it is a more potent drug. An IV bisphosphonate is more potent. Two, it doesn't depend on the stomach for absorption, but the biggest part is the compliance. Because when you're using an oral bisphosphonate, which can be very appropriate and very good for many patients, particularly those with osteopenia that don't yet have osteoporosis, there's a regimen to be done with those drugs versus if you're using an IV bisphosphonate, you just have to capture that patient for 15 minutes once a year and an IV, and they are treated for a year. So the compliance is huge.
And would you say the most common oral one is the Fosamax?
Yes, alendronate, which is Fosamax.
And that there's like some dietary restrictions and or tell me, there's some peculiarities about how you have to take that, correct?
It is a little bit cumbersome, but it's very doable. So that is a once a week oral bisphosphonate, and it needs to be taken on an empty stomach and only with water, especially not with caffeine, and wait at least 30 minutes before eating or drinking anything, preferably 60 minutes. Take it only with water and no other medications, and then not lay down.
Gotcha. But it's just a once a week.
Right.
Pill.
But that's a couple hours for that day.
Mm-hmm.
And you can use, Actonel can also be used once a week, which is ricidronate, but it's also once a month. And ibandronate, which is Boniva, is also once a month. And those drugs are somewhat effective. The data in Boniva is not as good for the hip and the spine as Fosamax and Actonel, but taking something once a month is sometimes a lot less cumbersome and improves in compliance with patients.
So there's no such thing as the free lunch. So every medication has some potential side effects. What are some of the more common side effects with something like Fosamax?
So with the oral medications, the most common side effects are stomach upset or aggravation of acid reflux. And then less commonly, but significantly, we see people that have muscle pain or kind of achiness, similar to what you hear about people having on statin therapies, and started by, that are caused by the medication, not giving you back pain that you already had. Does it make sense? And those are the big ones that really stop us from using the medications. Not a lot of people are really allergic to those medications.
Okay. So those are the class that you call stabilizers. And then you talked about the ones that will actually build bone.
There's one more stabilizer that we should talk about too, is Prolia.
Yes. Okay.
Which is a shot every 6 months. It's heavily advertised on TV.
And that's intravenous or intramuscular?
That's an intramuscular shot.
Intramuscular injection.
Every 6 months. It's a wonderful drug. It's very safe. It's the only really effective osteoporosis drug that is safe in patients that have significant compromise of the kidneys.
Now, is that the one that's also called Exgiva? That it has two different names, whether you're using it to treat osteoporosis or you're using it to treat bone metastases?
Yes.
Same medicine, but it has two different names.
And different doses.
And different doses.
Yeah. So
So
when you're using it to treat osteoporosis, it's 60 milligrams every 6 months. And then when you're using it to treat metastatic bone disease, or then you're using it as Exgiva, which I believe is 120 milligrams a month. Is that correct?
I'm not sure what the dose is.
It's quite a bit more.
But it's the same generic name, but
Denosumab.
It has a different trade name if you're going to use osteoporosis or to treat bone metastases. What do you know the pathophysiology or pharmacology for how it helps with bone metastases?
No.
Okay.
And I should say the IV reclass, the zoledronic acid, is also.
Yes. So I'm not a medical oncologist. I've been told that it makes the bone a little less fertile soil for bone metastases.
And fracture. So the other thing is, I don't know the metastasis literature, but with with fracture from metastatic cancer, for example, the reclass that's given once a year is given once a month in twice the dose. So you're getting 24 times
in
the
individuals
amount.
who have bone metastases.
Yes, to a bone that would be potentially catastrophic to break. That's from the standpoint of fracture.
Mm-hmm.
So, for example, in the spine or in the hip, where it could cause quadriplegia or loss of mobility, it's used at much higher doses.
Okay. And then let's talk about the bone strengtheners. And the names of those again.
So there are 3 on the market. The older ones are teriparatide, which is Forteo, and abaloparatide, which is Tymlos. And those are human parathyroid hormone, and they're given as a daily self-injection.
Subcutaneous, kind of like an insulin shot.
Yep, and a teeny tiny needle. They're very, very doable, and they're very good drugs and successful drugs. Patients have to get used to the idea of giving themselves a shot every day, but it's a 30-day worth of medicine in a syringe and a teeny tiny needle, and most patients are surprised that they can do it. You can use those. Originally, those were restricted to up to 24 months of use, but the lifetime limit has been removed on, I believe, both of those drugs, at least on Forteo, and those are bone building drugs.
And who would you prescribe those for?
So you could use those in someone that has very severe bone loss right as an initial treatment, but more commonly, and especially in Des Moines, because we have really good primary care in Des Moines. Try living in another state if you think Iowa doesn't have great medicine. We really do have good. We have good physicians. And so the more common situation that I find myself in is somebody who has maybe been on Fosamax for 5 years and still fractured despite that, or has a vertebral fracture despite adequate therapy with something else. Then we move to the bone building drugs. But you can start with them.
Okay.
Then the other class of drug, which is completely unrelated, is the newer drug called romosozumab, which is Evenity. And that is given once a month by a healthcare professional, meaning it has to be given in the office for 12 months, 12 consecutive months.
And that's an IV infusion?
It's actually just an intravascular injection.
Okay.
It's 2 shots, 1, 2, once a month for 12 consecutive months. And with any of those bone building drugs, you get this pretty dramatic increase in bone density. And then you have to put something else there to stabilize that bone density. So whether it's Prolia or Fosamax or the IV. Otherwise, you will drop right back to where you were. So there's
Gotcha.
no permanent
So
benefit
you
from
build
those.
it up, but then you stabilize it with the stabilizers.
Right, right. And romosozumab, which is Evenity, is a novel, really totally new drug to the market, and it works in a pathway involving some bone mediators called sclerostin. And it's a drug that is nothing like we've ever seen before. And it has we sometimes see 30% improvements in bone density. So
When would you go to that medication?
so I use that when a patient comes in with a new fracture despite adequate therapy. But there are times, for example, if I met a very vital patient, regardless of their age, with an extremely low T-score, meaning they have very severe osteoporosis, then sometimes you can get insurance companies to let you start with a bone building drug.
Okay. Let's now shift to the topic of osteoporosis associated with breast cancer. So that is such a common topic because, as you've already taught us, the relationship between estrogen and bone health is prominent. And in many women with breast cancer, they get put on anti-estrogen medications that can have an impact. So a common scenario is a woman develops breast cancer right around menopause. And if they need chemotherapy and they're premenopausal, often the chemotherapy will knock the ovaries out.
Right.
And a woman will go from being premenopausal to, in the course of the chemotherapy, slammed into menopause. And then, oh, by the way, when you're done with the chemo, then we'll give you some anti-estrogen medicines as well. So we see so often those women right around, the late 40s or 50s that within the course of a year go from premenopausal good bone strength to slammed into menopause, and then on top of it, anti-estrogen. Now, all of those are good for keeping the cancer at bay, but that
Which is
form of
supremely important.
very important, but has consequences on bone health.
It does. And it's interesting because Prolia early on got a specific FDA indication to use, as you know, with aromatase inhibitors, which are something that you use in breast cancer patients to prevent bone loss from those drugs. So you can, I see a lot of people from the oncology practice that are being started on an anastrozole or something like that. And even though their bone density is good, Prolia has the specific indication to prevent bone loss from aromatase inhibitors.
Gotcha.
And androgen deprivation therapy as well. So you can actually put them on a preventative medication and keep them from losing bone from those therapies.
So just to clarify, when you mentioned androgen deprivation therapy, so the two types of cancers where we're often in oncology talking about bone density, breast cancer in women, where depriving them of estrogen is a strategy in keeping the breast cancer at bay, but causes bone density issues. And in men with prostate cancer, especially men who have metastatic prostate cancer, we deprive them of testosterone as a strategy for treating the prostate cancer. But in men, testosterone is important for bone strength.
Right.
So as you said, now there is a medication that can be used to try to maintain bone strength for women that are on some types of anti-estrogen, especially those called aromatase inhibitors that are given to women after menopause, or for men with prostate cancer that are given what we call androgen deprivation therapy, things like Lupron,
Right.
that deprive the body of testosterone and consequently can make bone density worse.
Yeah. And it can be used preventatively, which is wonderful.
And what are some of the more common side effects of a medication like Prolia?
Prolia is a really well-tolerated drug. It's been very useful. We don't see many problems with it. There's an occasional muscle ache, but it's probably the best tolerated osteoporosis drug that we've had.
And if a woman, is, let's say a woman in menopause, and part of this is just repeating, but what can women do for themselves to try to maintain bone strength? So you mentioned the right amount of vitamin D, right amount of calcium, that exercise is important. There's a limit to how much you can build your bones, but having good, strong muscles prevents falls.
Mhm.
Other, avoiding smoking,
Right.
avoiding
Alcohol
alcohol,
intake, yeah. Avoiding steroids.
steroids,
Oh,
yes.
the other one that I'd like to mention too is there's a big market now for what people call adrenal boosters.
Hmm.
And I have seen it's bovine adrenal, and people have come in on these. It's essentially prednisone, and it's ground up bovine adrenal, and you can get it at some holistic or natural health stores. And I have seen people come in on adrenal boosters that make you feel pretty good and drop their bone density 30% in 2 years. It is just like taking huge doses of prednisone, and it's over the counter.
Gotcha. So it's got corticosteroids
Yeah,
in it.
scary.
Wow. What else should we know about osteoporosis before we open it up to questions? I know we're going to have a lot of questions.
I think the one thing, Prolia is a really, really good drug, but I think an important point to know about that is that it doesn't bind to bone. So it works out in the periphery in confusing the signals that tell bone breakdown cells to work. And so when you start Prolia, this is the shot every 6 months. If you stop that medicine or don't get your shot at the next 6 months, you immediately lose benefit from that drug, which if you want a patient off of the medicine for some reason is wonderful. That's not very common. But if a patient misses a shot for a couple of years or you want to stop the medicine, the bone density can actually get worse than it was to begin with. And so I'm reticent to use that medication in an otherwise young, healthy person. In my world, young is you're living alone and living independently. And regardless of your age, you've got longevity ahead of you because there's no stopping point. And unfortunately, Fosamax came out in 1990, and we put everybody on that. That was the first osteoporosis drug. And 20 years into that, post-marketing, we saw people walking up to get mass and just having their thighs snap in half and without any trauma. So that is what is called atypical femur fractures. And that was a result of oversuppression or overtreatment with medication. So now you hear about what we call drug holidays. And if you use the bisphosphonates like Fosamax and those types of drugs, you can oftentimes use those for 3 to 5 years. And if the bone density is stable and the patient's taking their calcium and vitamin D, you can stop those medications because they're actually absorbed into the bone and they'll stay in the bone for several years. So you avoid giving the patient too much medicine. In 1990, when we started Fosamax, after about 20 years, when people broke their femurs without any trauma, we realized that we had oversuppressed the body's ability
And
to heal
typically,
itself.
someone who breaks their bones because of that, how many years typically had they been
15 or 20 years.
15 or
That
20
doesn't
years.
happen in people that are treated appropriately with 3 to 5 years of that type of therapy. But you have to take into account the accumulative amount of time that a patient's been exposed to drugs. And in 21 years of practice, I have patients that I've treated 3 or 4 times, but each 4 or 5 years, I've given them what we call drug holidays, where they stop taking the Fosamax or whatever they're taking and just take calcium and vitamin D, let the bones wake back up and learn to heal themselves. And then we watch the bone density. And if the bone density starts to decline, or unfortunately, if they start to break a bone, then we return them to therapy. But that drug holiday and that time away from medication is really important.
One other question before we go to questions from the audience. Is there a genetic predisposition? Do you see
Absolutely.
Grandma had osteoporosis, mom had osteoporosis?
Yes.
I'm likely.
And particularly with the presence of hip fracture or vertebral fracture in a parent is a significant risk factor. I think I left that one off the list. That's a major
hereditary
risk factor.
Have we identified the mutation? I mean, it's not like with breast cancer, BRCA1, BRCA2.
Yes, it's the SG501
It is.
HLA-B 427.96. I have no idea.
Okay. But you don't typically get a genetic test on the patient.
No.
Like if grandma had breast cancer, mom had breast cancer, you'd be
No,
doing
there
a genetic
isn't one like
test.
something
So-
like
so
like
we
the
haven't
HER2 new and
actually
yeah.
identified it.
No.
If it turns out to be the number you just said, you
I
should
completely
buy
made
a
that
lottery
up.
ticket.
I completely made that up.
Let's open up to questions and answers. Now we've got lots of
one weight-bearing exercise you mentioned. So does it matter if you walk outdoors or on the track up here or on a treadmill to help with your bone density?
No. Weight-bearing exercise and muscle strengthening is vital and important and helpful any way you do it.
Okay. Also, doesn't matter how much weight you lift, 5, 10, 20 pounds.
I think that depends on what protoplasm or human body you're starting with and the actual strength. I mean, my mother, who's 91 and has osteoporosis and is doing really well, lifts 2-pound weights, but she does it several times a day and rides a bike. That wouldn't do me any good, probably, at being the young, virile 57-year-old.
Go, Mom.
Yeah.
Oh, I have kind of two questions here. You mentioned caffeine. Does the caffeine affect your muscles or?
Not your muscles, but there's been some studies that carbonated beverages aren't good for bone, and I think it comes back to everything in proportion. If you're drinking 8-9 cups of coffee a day, or like I do have some patients that drink 12 bottles of Diet Pepsi a day. Not good for any part of your body, and certainly not for the bones.
But in general, drinking coffee isn't associated with osteoporosis.
No, everyone should have coffee every day.
Yes.
Yeah.
But it's
just not too much of it.
sodas. No, not good, right? Caffeine sodas.
Everything in proportion.
Okay.
Everything.
And the second one was, I'm a 2-year cancer survivor, but when I went through the 2 types of chemo and steroids, being a type 2 diabetic, I went up to the A1C of 13.
Yeah.
So before I can have the surgery, Dr. T's like, no, I can't do it until we get that down. Being that I was on that steroid, how much should I be concerned? I should be having regular tests on my bone density. I'm not. The doctors put me on calcium and all that. The oncologist. And
So
vitamin D, but
just the fact that you are menopausal and certainly that you've been exposed to high dose steroids, you should have a baseline DEXA bone density test, and even if that's normal, that's worth you can get that monitored every 2 years.
okay.
Doing it more frequently than every 2 years isn't helpful. And I sometimes have patients that, especially if they're at a point of indecision, that they want to say, well, I want to check it 1 year from now. It's not a statistically finessed study enough to do more than every 2 years in most situations.
I'll be seeing my oncologist next month, so I'll make that up.
Next. Questions? Here we go.
I'm going to dummy it down a little bit here, first of all.
Please do.
Okay. So we're talking about a lot about osteoporosis. So in my mind, porous means no pits and stuff like that in the bone. So when you had osteoporosis, you had the bone degradation, but how does that look? I mean, is there really pits in the bone itself?
So if you look, it's interesting because we have samples of that are enlarged that are bone biopsies from the iliac crest. And when you look at a healthy bone, it's very dense and it looks like kind of a matrix of bone. And as osteoporosis happens, that kind of tends to dissolve away and it becomes more weak, more porous. Yeah. So it isn't holes in the outside, the cortex of the bone. It's more the trabecular or inside of the bone that breaks down.
So look more like a sponge with bigger holes.
Yes, that's a good
Oh,
analogy.
that's a good
That's a
analogy.
good
Yeah,
analogy.
so
I
you can
kind
have
of got that in my mind now. Okay.
Yeah.
So my next question, I'm thinking of joints and things like that. You got a bone there, then you got cartilage, and you got more bone around it. But if you have osteoporosis, the peripheral part of that, of the cartilage, and then the bone that's beyond the cartilage, is that affected by that osteoporosis that say might be in your hip?
I'm not sure.
well, the cartilage is different than the bone. So and correct me, but the outer part of the bone is like a shell of hardness.
The cortex.
That's the core. Yeah. And then as you get deeper into the bone, you get a bit more of a matrix. So one of the definitions of a fracture is that outer cortex, the shell, breaks.
Okay. And
But-
that was leading on to my
But the
next
cartilage
question too.
is not actually bone tissue.
Okay. So when you have a fracture, it actually fractures the outer harder end. So how do I know that if I have a fracture or not? I know I would know it if it totally breaks, for instance, because you got instant pain and then you're gone.
Yeah. And if it's sticking out of your skin or
Yeah. But how would I know if I have like a minor fracture where I have to start seeing a doctor like yourself?
so you're thinking like of stress fractures of
Hairline fracture.
or
Hairline
Because you really want to see
stress,
her
I-
before you get a fracture. So
Okay.
But I guess you bring up a good point because 50% of fractures of the spine, vertebral fractures, are not symptomatic, and they're just picked up on screening, which is always amazing to me because the patients that do have them are in a lot of pain for a long time. But 50% of vertebral fractures are,
not symptomatic.
yeah,
Hmm.
which is amazing.
You're right. So, and then in men, so I was in a bicycle accident, so plenty of reason to break bone, but I broke like 20 bones, and so they said, after I healed, we should probably have a bone density because you broke a lot of bones, and okay, that was trauma, but still. So, is that a one way a man might get referred? You said if you're 70 and a man, insurance will pay for a bone density, but under 70, insurance may not pay for it. It's just part of a routine evaluation, like it will pay for women over menopause.
Right.
Does a man who's had maybe more than their share of fractures under this age 70 justify doing a bone density?
Yeah. And my partners and I talked about how to present this to you because, really we want to screen anybody that we can that's at any risk with a bone density test. It's inexpensive, it's non-toxic, it's easy to do, it's painless. And so really any excuse we can find to do a bone density test, we try to do that. Our particular group of people are at very high risk because any inflammatory condition puts people at risk for osteoporosis. But sometimes the way that we work around trying to get a bone density for men is, yes, if you've had a fracture, for instance, a finger fracture or a stress fracture of the foot, or a facial fracture is not considered an osteoporosis fracture. But sometimes we can use that to get a bone density test. The other thing that we can do is we can sometimes look at an x-ray and see, yeah, the bones look a little bit thin on the x-ray. We should probably get a bone density test. And that is absolutely a matter of medical judgment, but it's a way to get people the treatment and the prevention that they need.
I have a question about weightlifting. So like when you do weightlifting, like a bicep curl, are you just strengthening the muscles and the bones of the arm when you do? So if you do weightlifting to help prevent or to help decrease the osteoporosis, is it just just strengthening the muscles of those bones that you're doing the weightlifting to? Does that make sense?
That's a tough question. I'm not a
Yeah.
personal
So
trainer.
I the way I would
You
answer
probably
it
know more, yeah.
is that you don't have to train every single muscle,
Right.
and that there is a abscopal effect. There is that doing weightlifting, let's say resistance training,
Mhm.
it doesn't have to be
Sure.
weights.
Mhm.
I mean, a push-up is resistance
Mhm.
training. Elastic bands is
Right.
resistance training. Climbing stairs is resistance training. Things that really engage your muscles probably result in various hormones and or proteins being released into the bloodstream that can have an effect on other muscles. So I would say that if you're only doing biceps curls, you may see muscle improvement in other muscles.
Because I was thinking like, because of the vertebrae, how do you get the vertebrae stronger? But if you just do general weightlifting or squats
Yeah.
or all that,
Standing
Standing.
is giving you,
Okay.
so as Dr. Hart said, and I'll let her, that it's hard with just exercise to make your muscles
Right.
stronger,
Mhm.
the amount that you can make your muscles, excuse me,
your
not
bones
muscles,
stronger.
bones.
2%, yeah.
Why don't you go ahead and reiterate that?
Oh, no,
point
you're the
about-
exerciser. You keep talking.
But that, unfortunately, even though exercise is really important,
Yeah.
as I've learned from Dr. Harts, it's really keeping your
Muscles.
muscles
yeah.
strong, because all your bones are encased in muscles.
Mhm.
And if you can keep your muscles stronger and not fall down, you're less likely to break something.
And stay mobile and be well balanced. I think what I'm thinking of when I say that is, I do have patients that come to me that have clear-cut, pretty significant osteoporosis, and they want to try weight-bearing exercise for 2 years and recheck the bone density test before they commit to a drug. And it never works.
Mhm. Yeah.
It just isn't enough. But it is vitally important to the overall health and the prevention of falls,
Sure.
because as you know, either from aging or watching people that you love age, once you kind of start to lose that strength and your balance becomes poor, it's a really tough uphill battle to gain that back. So staying in tune with that as we age is hugely important.
Mhm. Thank you.
Yeah.
All right. Well, we are at the end of our hour. This has been great. Thank you.
Yeah.
Dr. Kristin Harts, rheumatologist with the Iowa Arthritis and Osteoporosis Center on Plum Street in Urbandale. And we've been talking about osteoporosis. If you know someone that would benefit by watching this program is going to be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy One Cancer Center website. So please direct folks to that. And I hope you'll join us next week. Thanks for being with us.